Good morning. Can everyone hear me okay? That sounds good. Great. So my name is Ximena Portilla. I'm a research associate at MDRC, and it's a pleasure to be back here at Stanford. Thank you so much for the invitation. And today I'm going to be describing to you a program, an evaluation that is evaluating evidence-based early childhood home visiting programs. But first, I'm going to explain what home visiting even is. And so home visiting is a service strategy that really aims to improve outcomes for families and for children. And it does this by providing individually tailored information, resources, supports, and education to parents who are either pregnant, expecting children, or already have children, but they tend to be young. So we're really talking about the 0 to 3 range, sometimes extending up to 0 to 5. But really, this is the core age group. And the families tend to be disadvantaged, so they have lots of high risks and high needs. And home visiting isn't new in the United States. It has its origins in the 19th century when charitable organizations used home visiting as a mechanism for trying to, let's call it, improve outcomes by changing the behaviors for the urban poor in metropolitan areas. But since the 1970s, home visiting has really evolved, and different approaches have stemmed from different sectors that touch on early childhood. So in some cases, in the public health sector, it's really about registered nurses, public health nurses going into homes to try to target and improve child and infant and child health outcomes, but also child welfare service sectors, for example, providing family-based supports in order to prevent child maltreatment by promoting positive behaviors in parents. And a large body of evidence exists for the efficacy of home visiting programs. And in general, I guess I'll sum it up by saying that there have been some positive effects. But the effect sizes really vary substantially across different studies and across different outcomes, as you can see by these ranges, which in some ways seem kind of modest to large in some areas. But when you look at the averages, they're actually quite small. And one difficulty in interpreting the home visiting literature is that different studies measure different outcomes. And this has in part to do because all the different models have different historical priorities. They target different outcomes, and therefore they measure things in different ways. And so those studies have sometimes even measured their outcomes in different ways. So it makes it very difficult to disentangle where the effects really are. And additionally, the sample sizes have sometimes been very small, so it's made it hard to really understand for which types of families does home visiting have a bigger impact for, because subgroup analyses are difficult to come by. And even for those that did actually look at subgroups, they sometimes define them in different ways. So all of that being said, it's challenging to try to understand kind of the pattern of effects, but I would say, in essence, early childhood home visiting has improved outcomes for parents and children across a wide variety of domains, across a wide variety of models, and across different studies. And for those that have actually been able to track kids over a much longer period of time, it does appear to be cost effective. So with that body of evidence, and with the goal of providing extra supports to families that are at risk to really try to get their children off on a better footing for when they enter elementary school, in 2010, the federal government, as part of the Affordable Care Act, expanded investments in availability and evidence-based home visiting programs within the United States. So they created the Federal Maternal Infant Early Childhood Home Visiting Program, which is called MCV for short. And it's appropriated $2.7 billion since 2010. And I have to say, because my work kind of hinges on this, we just had reauthorization on Friday morning as part of the continuing resolution. And so the field is very excited about that. It's unclear how much money is going to be appropriated, but it does appear to be at the similar funding levels. So this program is administered through the US Department of Health and Human Services, and it's really a collaboration between HRSA and the Administration for Children and Families, ACF. And importantly, as part of the legislation, they included 3% of funds for research and evaluation efforts, which is really important given the gaps that already exist from the research I just described. And Congress actually mandated a national evaluation of the McV program as part of this great expansion of funds to states. And so this is the project I work on. It's called the Maternal and Infant Home Visiting Program Evaluation. And it's sponsored, again, by HRSA within the US Department of Health and Human Services. They're the ones that actually administer the funds to the state awardees. And OPRE, which stands for the Office of Planning, Research, and Evaluation. And I'll say that OPRE is the research arm of ACF, the Administration for Children and Families, much like IES is the research arm of the Department of Education. So our project team is quite large. MDRC is the prime contractor, but we also have a large team of collaborators and research partners, which includes research firms as well as academic partners, which I'll say is pretty unique actually for like a large-scale federal evaluation. My hope is a multi-pronged evaluation. It's quite large. And really at the heart of it is the random assignment impact study. It's an effectiveness trial, which means that it's studying the impacts of community-based local programs that are implementing these home visiting models that have been shown efficacy on a much smaller scale, but we're bringing it to a much larger scale. And additionally, there's this multi-level implementation study, which is both going to inform as well as enhance the results from the RCT. It includes the state needs assessment analysis. I won't go into too much detail there, but really the Congress wanted to understand, well, what was happening before they invested all these funds from the McV program, what was available within states and what communities were they trying to target. And then finally, it will include a cost effectiveness study, which will link the costs of implementing these program models and linking it to the effects that we hope to see as part of the RCT. So just a quick overview of the MyHope design. 4 models were chosen to be evaluated. That includes Early Head Start, it's the home-based option, Healthy Families America, Parents as Teachers, and Nurse-Family Partnership. And I'm not going to go into detail about these program models, but I will highlight that they have different goals because they have different historical priorities. They originated from different sectors. They have different intended recipients who's available for the program services at one point in pregnancy or depending how old the child is. And they have different intended service plans. So that includes the frequency of the visits, the duration for how long families should be participating. I will highlight these are voluntary programs, so families can drop out, after a month if they want, or they can stay, 2-3 years. It really depends. Our evaluation is quite large. We randomly assigned 4,200 families at 88 different local program sites across 12 different states. And mothers were eligible for the study if they were pregnant or if they had an infant younger than 6 months of age. And I'll say this is a much more narrow requirement than what's needed for home visiting services. So the legislation authorizing the McV program requires states to actually have different benchmarks that they need to hit in a range of different outcome domains. So this is really around process. How are they really tackling mental health issues with families, or how are they targeting positive parenting behaviors? But additionally, in the legislation, states need to be able to basically have movement for all of these outcomes. And the reason I put it up there is because it's really a broad intervention. It's targeting basically everything that might affect a family. And so the evaluation is actually examining all of these different outcomes as well. So, some of them are the usual suspects. All of the models target positive parenting, child development, but in addition, now they're being asked by the McV program to target behavioral health, so reductions in substance use or improvements in maternal health. Also targeting economic self-sufficiency of the family, when some of these might have just focused on preventing child maltreatment. So in some ways, McV has really taken a heterogeneous group of home visiting models and tried to create standards and create a level playing field across the entire home visiting effort in the United States. So we have a wealth of data that we've collected since 2011, And kind of at the heart of it is our impact evaluation. So our follow-up period, our main follow-up period, is the 15-month point. So the kids are actually quite young. They're only toddlers still. But we wanted to be able to assess the children and the families as close enough as possible to when they were receiving services. And so, it's a randomized control trial, so we're going to be looking at the effects of all of these outcome domains, comparing the program group to the control group. But because our sample size is large, we're going to be able to answer or contribute to this question of subgroup effects as well. And just to give you a range, we have a lot of administrative data, we have survey data, we have direct child assessments at 15 months, and we have videotaped interactions of the mothers primarily interacting with their children. We also have this, as I mentioned, this very in-depth multi-level implementation study. And we're asking some of these questions, we're actually asking more, but this is what I could share with you today. And so descriptively, we'll be able to provide information around the characteristics of the families that participated in home visiting, and importantly, how the services were delivered. A lot of information that exists about home visiting is about family engagement, but what that really means is, did they receive a visit or not, or for how long? But what we actually have are weekly service delivery logs that home visitors collected and completed about the content that actually occurred within the home visit. So for example, what topics were discussed, what screening procedures happened around what outcome areas or needs that the family had. In addition to that, what referrals were provided into the community agencies, and really understanding if the families followed through. We have a lot of surveys where we can begin to assess the characteristics that are associated with variation in service delivery at multiple levels, so characteristics of the families or local program features, as well as the other influence, which is these different models have these like national offices, and they have their own requirements that extend beyond the McVie program requirements. We have some qualitative interviews with home visitors that get at the home visitor perspectives of the challenges that they face working with a really diverse set of families and the challenges they encounter and how they're addressed. And then finally, because we have such a large sample of local programs, we have 88 different local programs, we're going to be able to leverage that design in order to understand not just mean level effects, but begin to look at what are the local program implementation features that might explain the variation in impacts. So I had really hoped to be able to provide you with some findings from our study, but unfortunately it's a federal project, and so I can't discuss them. And we're actually in the middle of basically producing all of these reports. So our implementation research report is under clearance at the moment. It should be out in May, and it's going to provide a very descriptive picture of what's happening across all of these local programs. And we have some multi-level, multiple regression models as well to look at the variation of service delivery, and we have the qualitative piece in addition to that. There will be a cost report, which will be a straightforward report looking at what it costs to implement these models, as well as our impact evaluation report, which will include the impact variation analysis and our cost effectiveness evaluation as well. So there's a lot of work happening. There's going to be a lot more dissemination happening over the next few years. But I will say that our team continues to be extremely busy. We have funding to design a long-term follow-up. So, as I mentioned, the kids were quite young at 15 months, and so we actually want to be able to see, what maybe we're not seeing things at 15 months, but it's because the children were too young, especially around child development outcomes. Perhaps the intervention is affecting parenting behaviors first, and then we'll be able to assess, what are the effects of the program as we look kind of into the future. So we're going to be looking at some of the similar outcome domains as before, but because the kids will be older, we'll be able to look at school readiness outcomes, academic achievement, as the kids get older, juvenile delinquencies. So, we're kind of in the throes of figuring out that design at the moment. And so just to end, here's a couple of resources to learn more about McVie and more about My Hope and the LT study. The HRSA website, because they administer the program, has a ton of information about home visiting and its expansion and how many families they're touching and kind of all the different benchmarks and things like that. And then obviously MDRC's website, which has a lot of information and resources about the evaluation study.